I became a physician?
I decided to become a physician when I was 4.
Basically the cliche answer that lots of people have, which is just actually to help people.
My decision to become a physician really began in my teens.
To help people, essentially.
We're in a very privileged position as family physicians. We get to follow people basically from cradle to grave.
Almost every day or week there's something unusual that comes across that I haven't seen before or that I need to look up. And so I find this job always keeps me on my toes.
So the physician learning program has a lot of elements that I am familiar and recognize because of my background from the United Kingdom.
It's a great opportunity to be involved with clinical research and also to see how my anesthetic techniques specifically affect the outcomes with regards to pain and nausea and vomiting and those types of things.
We were interested in following up the children after they've gone home after surgery. Give them a telephone call and ask the parents of the families and the children that are old enough, basically how was your experience at the hospital? What did we do well and what could we do better, in the broadest terms?
Participation in the physician learning project at the Children's Hospital was fantastic. I mean, from the get-go. First of all, there's an entire team that comes in and helps us.
As a practicing physician, we don't have time to do all of that stuff ourselves. There's a lot of work that goes into that, and the physician learning program seemed like the best way to get access to those resources.
They were able to sit down with us and figure out what our needs were.
It allowed me to highlight my other patients that were taking antipsychotics who were moving up into that older age range, so that I can now keep a watch on them and decide whether they should continue on that medication.
In the terms of clinical practice guidelines, it's okay to go outside the boundaries of recommendations if it's done in a very systematic way with a clear assessment of the risks and benefits, talking to the patient and monitoring if they go ahead with that, and then coming back within the guidelines if there isn't a clear benefit.
In terms of the post-operative experience of my patients, one of the things that I did learn for myself is I give a little less, for instance, opioids intraoperatively, and my patients do need a little bit more opioids when they're in a recovery room, which means that they do receive opioids and may stay there for a little longer than some of my other colleagues.
For me as a researcher and educator, it provides me with the opportunity to integrate the knowledge from different areas and apply it in practice.
The thing I learned is that I'm very similar to a lot of my colleagues at work. So as an anesthesiologist, we kind of work on our own in the operating rooms. I don't see what my colleagues do on a day-to-day basis.
The best part for me was the feedback session that we had, the discussion where I was able to sit around. We had quite a good turnout. We had probably 60 or 70% of our department there. I was just able to learn, especially from some of my more senior colleagues, we used to do this for this and now we do this, and I see a lot of people are doing this.
With regards to tonsillectomy, that gave me a chance to see that, yeah, I fit in terms of my colleagues.
You're just able to make little tweaks, nothing major to your practice, but little tweaks that for a given scenario are just gonna, I think, make the patient experience that much better.
Other things that I learned was how patients do 24 hours after the surgery. That's something that's the type of data that we don't typically get as anesthesiologists. So we got to find out, are patients back to normal function the day after? Are they suffering with pain? Are they suffering from other side effects from either an anesthetic or the surgery per se?
This is a good way of picking a particular topic that you might have an interest in, looking at it in a little bit more detail and making sure that you are truly following those guidelines, or to the greatest part that you can.
It gave me the possibility to explore a very, in this case, narrow focused area. So kids who are undergoing tonsillectomy and how my anesthetic technique actually influences their surgical outcome.
This gave actually a real snapshot of what is occurring in our hospital with our patients. not sort of reading a study that was maybe published in Denmark or France or Australia, where you don't know what the hospital infrastructure is like. It's sort of a totally different routine. These kids went through our day surgery unit, through our operating rooms, through our post-op unit, and then went home in Calgary with all the local factors here.
The Physician Learning Program offers a simple, effective, interesting way of providing self-audit and accumulating continual professional development points and improving their patient care.
Something that we don't get a lot of feedback on is our general approach with parents and the children we treat. As part of this report, we got great qualitative, very rich data from parents' comments on what is our general approach when we see the patient, bring them into the induction room, how we communicate with that patient to make them feel comfortable. So those were excellent comments, excellent feedback that I welcome very much about my own very specific practice.
I have changed some things about the way I give post-op pain meds for tonsillectomy patients in certain situations. I know a number of my colleagues have changed some of their post-op nausea and vomiting management for tonsillectomy patients.
As family physicians, we spend a lot of our days deciding which drugs to choose, how to manage our patients, how to reach these many targets that we are being put in front of us. This is just one way of making life a little easier for us.
It just adds and just makes the patient experience better.